me, we are still looking for another microphone. Okay, it's there. Perfect. So we need to start. So this is kind of the most, maybe the most, well, I wouldn't say the most important moment of this workshop, but it is certainly the one that we bring the four working groups together. And we are kind of running a bit late because we will finish at 1 p.m. So we have like, I was thinking like 15 minutes for each working group with, I would like to ask the rapporteurs and chairs in some, or you are all rapporteurs maybe, to make it short and then open up for discussion, questions, comments, remarks, and so on. So, okay, so we start with working group 1. Yeah, it's up there.
Okay. Good morning. I'm not Sabrina, I'm Terje, and I'm the rapporteur of the working group 1. So we discussed in our, oops, now I did something wrong.
Yeah, excellent.
But that is not what I am looking for. Okay, that is what, yeah, here. We discussed three points what we thought are most important. It is the role of the health literacy in order to be engaged you have to be aware and knowledgeable. The transformation about the role of patients towards the disease through data management, and that's where we mostly discussed an access to data and possibility of data sharing. And then the third question that we addressed was related to the patient and public engagement with our health services. So in all of these three questions, we actually agreed on some points. And they are related, they came out all with the discussion of the question number 1 on related to the health literacy, but they actually concern all three. And the two first most important things is to map what is existing, to map the tools, and to map the experience, because in the group it came out that there is a lot of experience in different fields, in different levels, with different objectives that exist, and people just should be aware of what already exists in order to avoid reinventing the wheel. And secondly, to map what the needs are. So if you know what the needs are and you know where the already solutions are, then it is more likely that you identify the gaps that you can work with. So we agreed on health literacy in two aspects, that it is not only about educating people, but it's also about educating healthcare professionals, and healthcare professionals in very wide range, including the doctors and nurses, but also we spoke about the pharmacist, about the importance of physiotherapists, as well as importance of informal carers, and of course, in the end, and most important, is the health literacy of citizens. And we should use all possible tools for it, different channels, experience that exists, the results that have been demonstrated. So the tools are quite different. And what we agreed that the challenge for achieving it is certainly the engagement on different levels. And we all agreed that here as well you need to engage the experts, such as the communicators, the professional communicators, those who are working with the public relations. Then also what we found important is to work with trustworthy sources. Dr. Google doesn't always qualify for that purpose. However, that is another difficult task, is to identify where the trustworthy sources are and how to guide people to this. So different options were discussed, and one of them certainly came out was the engagement of doctors and sharing this information about the trustworthy sources. Also, what is very important is the work together with the patient advocacy groups. If we don't talk to people we want to work with, then the result probably will not be as expected. The roles of different doctors were discussed, and in particular it was emphasized the importance of health literacy of general practitioners. And the modernization, using the massive open online courses for the education, or working towards the modernized patient information leaflets in the pharmaceutical packages, that all serves the same objective, to improve the health literacy. Then the second very important point that we discussed was about access to data. Even the General Data Protection Regulation gives people a right, and it is the human right, and it is all related to your health data. Also, the term ownership is not mentioned in the GDPR. The right to have an access to this information exists. However, these possibilities to exercise that right are very different in different member states. So one thing is to have an access, the other is to use this information that you have an access for. Also, what was heavily discussed yesterday as well as today was the question about interoperability. If we want to do some kind of scientific work with this information, or even provide a healthcare service for a patient in another member state or in another region, what is the situation with an interoperability and the data sharing, understanding this information and how this technically would all be worked. Also, we discussed about the need for patient-generated data more to be used. For example, to use more effectively in the area of personalized medicine also the patient-reported outcome measures and the patient-reported experience measures to become part of the normal health record. And also what came out often was about the patient engagement in clinical trials. And what was highlighted in that context was that people often are well informed about the point when they are invited to participate or asked to participate in the trial. But often the results of these trials are never reached to the patient. So that two-way channel of information sharing also should be informed. So the challenge here that was all agreed with is to implement more at the member state level the EU recommendations as regards the interoperability, for example, of data, health data, storage and sharing at different levels, because sometimes it is also not the data accessible across the street, not only across the borders. And what is very important is that we use the already existing policy initiatives, for example, the health data space, but also other options that have been worked on and have been developed. And finally, we discussed the question of trust and how to engage patients and public with their health services. Here we spoke about the communication among the patients, so that the social networks and the possibilities that they offer could be used at their best. They use the patient group as peer groups, so that my own experience would be probably the trustworthy source for other patients. Use the existing examples, the good examples, or maybe also those that don't work, to share and learn from them. And we also discussed this topic about the personalized medicine in terms of its content quite a lot, and sometimes it created rather controversial views on whether information that we have about the effectiveness of personalized medicine is now ready to be communicated to people, because it may create an unexpected or unjustified hope, or it should be limited to some extent to what we can do or what we cannot do. But it also turned out that we quite heavily focused on some specific subjects, and that we really cannot give the very big promises sometimes yet. And the other hand, we were speaking about the personalized prevention and all these aspects that are concerning the public health. So sometimes that's why we put in this last bullet point the personalized medicine, as it looks like we are dealing with a person, and the public health where you deal with population. And in principle, they should work together and should be used in both areas and for both objectives. So the challenge that we identified here is about the training the patient advocacy groups, but that also concerns the first point very much, to work with language barriers, in particular with regard to data sharing, and really choose the benefits that should be communicated. I think that on the prevention area, we can be more positive. In some areas of oncology, we can be rather positive, but in some, not so much yet. So the messages have to be tailor-made. So that is, in conclusion, what we discussed in the Working Group 1.
Thank you so much, Terje. So let's open up for comments from the working group members or others. Comments, remarks? Microphone. Who is in charge of the microphone? Yep, so down there.
Did you discuss about the patient as an expert, the expertise of the patient?
Yes, we
and
did.
what? Yeah.
Absolutely, we did. That was hand in hand together. That was hand in hand together with this understanding of need for educating patients and the need for using information that the patients have. Because who else knows the disease better than the patient who lives with it 365 days?
Yes.
Thank you. Very clear exposition. I would like to suggest, if you put in the list of healthcare professionals, also psychologist, dietist, nutritional expert, because now we need also this kind of thing. I don't know if doctors means also specialists, because fragmentation of medicine could be a real problem.
I fully agree. We even discussed about at some point the profession as the personalized medicine specialist, which I think is not the case. I think that the personalized medicine, every expert should be aware of how in their particular specialty it works with. I fully agree that there is a lot of people who should be in this list. We just had one slide.
I thought I saw many hands, but
They all had the same question.
yeah. But I really think we all agree that when we talk about healthcare providers, we mean all disciplines. I think it's very important to stress that this is not only physicians; it's really the whole spectrum of healthcare providers. Well, in that case, let's move on to working group 2. Please, Eva.
Uploading. Yeah. So I report about what progress we made today from the presentation yesterday. And we had this 3 leading questions on incidental findings, on informing patients, and on evidence-based medicine and fast translation. And we tried to come up with recommendations in these 3 fields and address the recommendations towards 3 levels of addressees. Can you forward the next slide? It doesn't.
You can do that.
Doesn't work.
No?
No.
Could I test? Let's see. Is this one?
One back. Yeah, these are the 3 levels, so that you understand. And after every recommendation, there is a level number. So recommendations could be addressed at the research level. So for researchers, PIs that are planning studies in personalized medicine, that would be level 1. Or it could be at the health service research level or implementation level, so more data needed to understand how policies are working or how they can be informed. And the level 3 would be the more general level at the health system or the authorities that need to learn or need the information. Now it works again. Wonderful. So for the first question on incidental findings, we have 7 recommendations. First, to harmonize and clarify the definition of incidental findings, because you restart the discussion all over again if it's not clear what you're talking about, whether returning to the individual or you are reporting research results. That would go on all 3 levels. Then we have the recommendation to the researchers and the ethics review boards, also the authorities, that there should be a policy in place that speaks to incidental findings in each research project, and that should include, and that there should be language included in the informed consent documents with that speak to incidental findings, and maybe also criteria to choose, or return of results packages to choose. The option not to receive incidental findings should be guaranteed in each study. The policy should also include a process how incidental findings would be returned if this is offered. And that can include the validation, the communication process to the MD, pre-test and post-test counseling. A blanket no-return policy might interfere with the participants' right to access their data. So we are reluctant to recommend a no-return policy, a blanket no-return policy. And context, we need more information and context-specific policies, especially for children, newborns, relatives affected by genetic results, impaired decision-making capacity, adults, and vulnerable populations. So it wouldn't be kind of one size fits all the context, but we need specific policies for these groups. And as we said yesterday already, returning results needs resources, so that should be integrated in the, if you write up a project proposal, in the cost calculations. So we also said for this area that more research is needed to inform these policies on what kind of return categories are meaningful to the participants, but also to the other stakeholders. We would need to know the long-term effects of returning incidental findings for the different categories also, whether these are actionable, certain findings, or findings of uncertain significance. There's no research out there so far. We would need implementation research if positive lists, so lists of mutational mutations that are just asked for, like the ACMG list, are used. And we need conceptual research for these context-specific policies for children, newborn, mature minors, and vulnerable populations. We don't have also the conceptual basis to draw good policies. And as we have already suggested yesterday, one basis to start with would be to collect experiences with the handling of incidental findings through additional requirements by ethic review boards and funding agencies, what they want, and to collect cases where it was either a negative experience or a positive experience because you did or did not return incidental findings, and collect data on the follow-up costs. So this was our recommendation for the first question on incidental findings. Second field was on the informing patients adequately and the tension between data provision and protection of a person's privacy. We had kind of content recommendation that information for the participants should include information about the benefits, whether it's individual or collective, privacy and other risk. That would go to level 1, so what the researcher should write in his protocol and in the information sheets. But more than just informed documents, we recommend an information process that should make the research transparent in a respectful manner to the needs of the participants, and should be offered on a continual basis. So not one-stop information and that's it, but an offer to an ongoing information process about the research that is going on with the data. One step to improve this kind of information and tailor it to the different populations is getting patients and participants involved in designing consent forms and information programs, and organizing the information at a group and a population level. We also had a then broader debate about a social debate and deliberation about the legitimacy of massive data collection and processing for personalized medicine. So that would be on a larger scale, what are the legitimate reasons to collect and process data. Not only consent is a legitimate reason, but that there needs a deliberation and consensus building in society. And we need, that's a side point, to the informed consent documents, again, establish guidelines for participation of persons with impaired decision-making capacity. So also for this field, we have more research needed, how to include participants in the designing of information and consents in the best way, how to design information and consent structures for participants with impaired decision-making capacity, collecting experience with different consent models, dynamic consent, broad consent, or trustee ideas for participants with impaired decision-making capacity. Then a collective discussion and deliberation on massive data processing would need to be organized and researched, and the influences on participant expectation for the personalized medicine by direct-to-consumer and media, that speaks more to the first working group, would be helpful information. So the third area of debate was how to leverage the tension between evidence-based medicine and fast translation. And I said yesterday, fast translation does not necessarily mean that it's no evidence, but in the area of personalized medicine where we treat patients without robust evidence for efficacy and run the risk for side effects that we don't detect and costs that we just generate without knowing the benefits, it would be helpful and necessary to collect real-world evidence about benefits, risks, and access to personalized medicine, and that would prerequisite for this would be adequate data collection in an interoperable way. So the FAIR principles are important in this area and crucial. Then we had a debate about the guidelines for validation and quality control of diagnostic tools that need to be more explicit so that they can be implemented, and guidelines on the declaration on conflicts of interest in research in personalized medicine. So that were our recommendations. I'm very curious about your input and your thoughts about the three areas.
Thank you so much. Oh, sorry.
Yeah, thank you.
Thank you. Okay, let's open up for comments, questions.
Thanks a lot. Did you discuss about the mean to collect the consent and a time frame? Because as far as I know, in most of the cases, it's collected during hospital admission. And in principle, this is not the best time in your life to give an informed consent. And that's why in Switzerland, we are thinking of delaying this a little bit afterwards, using an electronic consent. Did you
it's a good point. We discussed the timing, but more in the sense of that it's not only one-stop information process. But I take that on our list that the means and the timing also when entering the hospital, if it's a patient. If it's not a patient, then it would be more on a population basis. What the ideas are. Do you have suggestions? What your recommendation would be in leverage?
I don't have this in mind, but there is a working group in Switzerland, and they are close to release guidelines, so I could transfer this, of course. Yes.
I have a question, something that is not very clear for me. You wrote there that since in personalized medicine we treat patients without robust evidence. I think that's pretty much a generalization. It's not clear for me that that's always the case. In fact, I would say it's the opposite. In many cases, there's robust evidence for treating the patients using personalized medicine approaches. So I find that sentence there a bit... I don't know.
Well, it
debatable?
was the leftover sentence. So the first sentence was that fast translation does not mean that it's necessarily weak evidence, but there are areas in personalized medicine where we do that. For example, the whole molecular tumor board off-label use, it's almost always a rationale that is either on just a molecular basis or a case series of phase 1 evidence only, and not the normal standard of phase 3 or adaptive trial design. And there we don't, if we just treat the patient and don't have a follow-up or a registry to learn about what happened afterwards, that is not justifiable. So for these cases in this area, we need kind of a follow-up and to learn from patterns. That it's only in that area.
I didn't get the connection, so it's clear now, because I reading the sentence just by
does not
itself,
mean all over personalized medicine.
Okay.
Sure.
Thank you. I think referring to the third point, you say you have. Could you put?
I can't move that anymore.
Okay, you are. Yes, no.
I think it's the next presentation already.
You are referring to the certification and for the in vitro, yes, validation. I think it is according to the European law. It is not EG, but it should be. It is a must. And additionally, I will propose to include the MDR. That is the regulation which will be a must for all software tools and all information. We are talking about the database and software tools that has to be done in there.
I will add that to the list.
I wanted to comment on the timeline that you already underlined. The timing was discussed in information, in consent, and in return of the results, because there are a necessity of not doing everything at the same time, or there are better times than others in those 3 areas. So it was not only for the consent that you need to think about when is the best moment to consent to this or to that, but also in terms of giving information all along and even after and during a project, and also to distill the results, because according to the different kinds of clinical context, it might not be a good idea to come with a lot of different results, some of them being really connected to the patient problem, and some others being more for the future actions. So maybe thinking of the timeline is very important for all domains that we discussed.
Okay, we need. No, I think we should. We actually perfect on time, so we need to move on to working group 3. And Jacques, please.
Yeah. Thank you very much. So I will try to summarize what was discussed in the working group number 3. Doesn't work. Yeah. So in this working group number 3, we had to address the issue of what are the issue related to the transfer of research results into the market, how to optimize a safe, fast, and economic process to implement personalized medicine approaches. So we had yesterday a very constructive discussion that I summarized. This morning we had another discussion, and I must say that it's not very easy to capture and to summarize all the points that were discussed. So the particularity of the discussion this morning is that we raised a lot of additional questions that came during the discussion. The first one is what is specific for personalized medicine if we consider the transfer to the market? What is specific for personalized medicine? Because there are a lot of obstacles or of bottlenecks to access the market that are non-specific for personalized medicine project and that are really generic. And so I think that it is difficult to define exactly what is specific. It could be on the treatment side, and we had an example of, for instance, the development of tissue agnostic indication for treatment. So this is very specific for personalized medicine, but especially for personalized medicine in the field of cancer. And this is what is addressed through the basket trial, meaning that there are the treatment are given not for breast cancer or for lung cancer, but for cancer with RAS mutation or tyrosine kinase mutation and so on. And the other aspect is the particularity of the diagnostic, meaning that especially when you consider diagnostic and stratification not based on one single biomarker, but on profiling a combination of multiple biomarkers, and this exercise corresponds to the establishment of new taxonomy. It is a new way of thinking of representing the medical complexity, and this is another area of research that is specific for the personalized medicine. But it's not easy to provide a single answer to what is specific for personalized medicine. The second question that was discussed also is something regarding the funding mechanism, because of course there is a need to support research and development in this field through public funding or public-private partnership funding. And here the instrument in fact already exists, because when you consider the different steps in the development of personalized medicine solution, this starts usually with a diagnostic, biomarker, and stratification step. Then there is a translational step, and then a clinical step. For each of these steps, the funding mechanism already exists, meaning depending on the TRL level, there are different solutions, either the ERC or the EIC, and different solutions exist. So the question is to understand whether it makes sense to try and have a specific funding program for personalized medicine, or if personalized medicine should be just one aspect of medical research and stratified following the TRL level. A third thing that was discussed over and over again during the panel discussion this morning was the issue of market access versus the arguments to convince the health insurance, the payers, and the HTA for implementation, because you can access the market if nobody is able to reimburse or to pay for your solution. You will never get into the market. And this raises a lot of questions. What are the arguments that are expected by the HTA? So we had partial answer, but I think there is a need to have more answers. One of the solutions would be to have a clinical trial able to demonstrate the effectiveness of the treatment and the cost effectiveness of the treatment, meaning trial on comparative effectiveness research showing the superiority of the personalized medicine approach when compared to the non-personalized approach. And I think this trial can be a joint trial, meaning it's possible in multi-arm trial to have trial that demonstrate both the efficacy and the effectiveness. And I think this would be a way of saving time, because if you do that, you can have in a single trial not only the argument to access the market, but also the argument for the reimbursement of the product. And a fourth thing that is important in the discussion we had this morning, that it is the fact that the industry was missing, and it is important to have the industry on board to share the experience with the industry. It doesn't mean, again, that all the personalized medicine research should lead to market access, because, again, I think some personalized medicine solution are solutions that does not require a new marketing authorization for the diagnostic, nor a new marketing authorization for the product. It's just a new procedure to stratify the patient that lead to the treatment decision. So I think the next one is the bottlenecks. So I think there are some bottlenecks that were identified, and there is a need for addressing these bottlenecks. The first one is the need for early support to design the development plan. It's obvious that personalized medicine is not something common, and there is no one-size-fits-all definition of the development plan for new personalized medicine solutions. So it is extremely complex. It is new. It is changing, because, as I mentioned, personalized personalized medicine started with a single biomarker approach, and now we have a very complex biomarker profiling, and this requires to have a specialized support structure. Here, typically, we need really specialists in terms of technology transfer for personalized medicine, in terms of regulatory expertise for personalized medicine. We need also some sort of scientific advice. So I don't know exactly who could provide this scientific advice, but this is something that is very important. And we have also to have expertise among the payer and the HTA in order to explore how far the personalized medicine solution that is under development may reach not only the market, but also the reimbursement. There is a need for training in personalized medicine, product development, market access, HTA, and so on. This is very important. There are also specific challenges regarding the intellectual property, the data science, especially if we consider the machine learning stratification, and expertise in terms of regulatory overseeing the development of personalized medicine solution. And also, and there were some economists in the room, I think there is a need to develop research on economic and economic expertise on to understand and to be able to demonstrate how far the personalized medicine solution will not only provide an optimal delivery of healthcare, but also will contain the cost of the healthcare. And the last slide refers to what we put forward as the roadmap for the next step. So I think first of all we have to build on knowledge through training, through support structure, and expert advice. The second thing is that we have to really promote the involvement of the health insurance, public or private, and the HTA in understanding what will be the real economic and healthcare added value of the personalized medicine solution. Need to identify what are the industry expectations, both on the therapeutic and the diagnostic aspect, and need for more venture capital investment, at least in Europe, because this is one of the identified bottleneck in the development of this risky activity, I would say. Thank you very much.
So, questions, remarks, comments? I do agree that we should have more representatives from the industry at this workshop. Something we need to consider next time, absolutely. And how to engage with industry in all different activities anyway. But yes, absolutely. Yep. It's not easy to, I should say it like this, when it comes to patients, it really depends if you want representatives from patient organization or, professional patients. And when you invite, my experience is when you invite patient organization or patients, you really need to emphasize why are they here, not like just a discussion partner. We really need a clear message. So,
thank you very much for the very good comment. I think we could ask for advice, scientific advice, the ESPT, that is the European Society for Pharmacogenetic and Therapy. And on all what are biomarkers you find there, all the really highlight professors and scientific community. And it is in Europe already. We just have the last Congress 2 weeks ago in Sevilla. I can give you the contacts, and they will be happy to collaborate. And it's a very serious, worldwide recognized organization.
Thank you. I think it is a good idea. We have also to consider that this personalized medicine approach corresponds to a very broad spectrum of activity, because you need this expertise, for instance, in pharmacogenetics, but this is about treatment, and this is about genetic predisposition to the response to treatment. I think there are very different aspects based on multi-omics and machine learning also, and people have to have also this expertise. So I think it could probably not be one single institution doing that. It could be a group of experts with different competencies in the panel of experts providing support and scientific advice. Yeah.
You are right. And at the organization, I belong to it since 6 years, and we have experienced the progress and advance. At the beginning, we were working only on pharmacogenetics, and meantime, then we are facing the same problems and also many other areas, I think, but it could be a good cooperation.
Because I think so the personalized medicine started with genomics, but now in many fields, so of course in the field of cancer, of rare disease, genomics is still very prominent, but I think there are many other areas where the phenotype of the patient is determined by complex profiling with proteomic or metabolomics that are far closer to the phenotype, and the question raised by this sort of approach are very different from the one raised by the genomic approach.
Hi, just only a short comment regarding the cost, how we reduce the cost. I think that we need to start now as a long-term goal, more in investment in preventive and predictive medicine, so you can reduce, because actually, as a personalized medicine, I think the concept is a personalized therapy. And so it is increasing the cost using a new technology and so on. So we need to start now for long-term vision, just to move from personalized therapy versus predictive and preventive, so you can reduce the cost.
Fully agree. The personalized medicine also includes personalized prevention, and this is typically a way to save money. And this means that, for instance, in the dual representation of the two poles in personalized medicine, the diagnostic and stratification and the therapeutic one, it's possible also to just remove the therapeutic component and just to work on new taxonomy of disease, new identification of homogeneous phenotype that can be exposed to different treatment or to different prevention strategy. Very good point.
From an industrial point of view, I can say some comments about the pathway from a prototype to a product to a market access, because the problem is to look at the production, very high quality production, and this after the European research, you have to shift to industrial behavior, and they have a lot of cost for the efficacy evaluation and for the safety evaluation. And for safety, depend on what kind of device you have to look at. For diagnostic, you can have surveillance, and for different type of device, wearable sensors, you have to validate the measurements also after market. Otherwise, the will be block the production and go away to repeat and circle the validation and the validation of the device. For implantable device, we have already a lot of data coming from the implanted device, but these are property of the industry, because they are very, very difficult to be considered, and different industrial partners don't like to share their data.
Okay, thank you. We need to move on to group 4, please. Tony.
Well, as I said yesterday, one of the advantages of being group 4 is that I can happily see that we are, from different perspectives, reaching to the same end. So it's just fantastic. Also, would like to mention that something that I think is really, really inspiring. Lisa Maria Wopio, who presented yesterday the Finnish strategy, always say something which I think is very interesting, that personalized medicine is not a revolution. It's just an evolution. It's what happens in human history. I mean, suddenly we face a change and we decide to move forward. And I'm happy to see that today we are demonstrated that yes, we can. We have ideas and we have initiatives and we have the strategy for moving forward. Anyway, so group 4 was the group that, as you know, focused its discussion on implementational elements. And that's why the group was so large. The leading question, just to remind you, were what interventions we should do at the design level, at the institutional and the healthcare system level to successfully adopt personalized medicine, what the specific needs need to be considered at the patient and population level, and how to translate the knowledge that is generated by science into efficient personalized medicine intervention. We had a very interesting discussion with several recommendations. We packed them together into the same box, because actually I think that we are converging in a number of recommendations that tackle the same issues. And basically the list of recommendations that now we are going to share with you, they have been presented around, I would say, 3 main pillars. One would be empowering the patients and the public, creating a real framework for the participation of different stakeholders that are all part of the same value chain. The second would be a specific emphasis on the policymakers at the healthcare system level, because that's the place where implementation should exist. And the third one would be to develop some sort of a structural framework for specifically actions that will move forward the implementation process on personalized medicine, taking into account evidence and the right assessment framework, moving beyond the classical concept of cost effectiveness. So the recommendations are, first one, and I would like to emphasize this one, is to promote the creation of personalized medicine roadmaps at the place, at the site where personalized medicine has to be implemented, which is the national and the regional level. These roadmaps with actionable plans should be based from the science domain, creating and generating a strong research agenda focused on the generation of scientific evidence. It is important, in order to harmonize the different voices that talk about personalized medicine in the context of the European landscape, to create and disseminate a set of criteria that define what personalized medicine from a prevention on interventional therapy point of view is, and very important in order to move forward and to generate trust and to involve the patient community, the policymakers and the public in general, to create a portfolio of successful cases of implementation of personalized medicine interventions and share them with entire society. This is possible, and this could be a really inspiring element for adopting personalized medicine at the global level. It is important that ICPerMed can play a very important role in generating policy materials, white papers or other kind of policy materials that support the development of necessary legislative and regulatory changes and adaptations to reassure the adoption of personalized medicine. Otherwise, that would be a barrier that will slow down this process of adoption. It is also very relevant if we want to really bring to the reality personalized medicine in the healthcare system, to create an integrated pipelines that must be adapted to the reality of the national or regional levels where personalized medicine has to be implemented. Pipelines that define the specific roles of the different stakeholders that participate in that value chain. And that means patient community that has to be empowered for progressing in the adoption, policymakers, academia, clinicians, healthcare providers, and reassure their effective participation. And of course, industry and developers are part of these pipelines. These pipelines should be defined at the regional and local level. We had a beautiful example from Finland that is working in the Finnish landscape, but we should adopt the same strategy in other places at the national or regional level. Of course, the key word here is co-creation, because we are creating novel processes in which different stakeholders participate, and this co-creation must be done with the patient community. And there are beautiful examples. This is just one element. We should, what I've done, sorry. We should co-create with the patient community, personalized medicine adapted informing concerns for clinical research in the healthcare domain. It is important also to develop, based also on this co-creation process, a framework, an ambitious framework for assessing the efficiency of outcomes of personalized medicine intervention. And to do that, we need to use properly high quality electronic health data. It's important to generate standards and guidelines for large European population studies, because from the prevention side of personalized medicine, we have an enormous capacity for working together, develop elements, develop biomarkers for proper stratifications for further interventions at the healthcare domain. It was mentioned before, I would like to make a comment, how important it is to develop specific training programs on personalized medicine. And in order to clarify the different work groups that participate, we propose to use the term healthcare workforce, which means all professionals that have a particular role in deliver a healthcare intervention on the community. And that, of course, includes all doctors, nurses, but also, as has been mentioned before, dietitians and so on. This concept of the healthcare workforce of professionals that have different responsibilities, but whose ultimate objective is to deliver a healthcare intervention or a prevention intervention. It was suggested, and I think it is a very interesting idea in order to accelerate the adoption and break the barriers that exist at the regional and national level in the healthcare domain, in the decision makers, to put them together under the umbrella of ICPerMed. So we propose the creation under the umbrella of this organization of a forum of policymakers coming from the healthcare system, the healthcare domain, with the idea of putting them together and share experiences and suggest common initiatives, common actionable ideas. Of course, there are barriers that need to be broken. One of them is the still different domain that the research community and the healthcare community occupy. So we need to integrate the healthcare professionals into the healthcare community. And two suggestions at the funding level to accelerate the generation of evidence for personalized medicine. Funders must support the development of independent clinical trials to promote the adoption of personalized medicine solutions, because these innovative solutions will come from this domain. It's very important, it has been also mentioned before, this concept of cost effectiveness. We propose to broaden the concept of cost effectiveness and talk about the importance of funding and supporting HTA evaluation studies that should include research on harmonization on already existing HTA frameworks for personalized medicine interventions, because that should be the way to reassure that the solutions that will be developed from the research domain will have an efficient scenario for being implemented. Very important to identify specific interventions at the population level to promote preventive personalized medicine care. We must always be aware that personalized medicine is not only about therapy, it's got an enormous area for development and for developing solutions at the population level, and prevention is an essential element of the core concept of personalized medicine. And although ICPerMed is a global organization, we are global, mostly focused on Europe, but we must be aware that this is a global challenge. There are other organizations, other colleagues all over the world, in distant places, America, Asia, Australia, Japan, that are working with the same challenges that we have. So ICPerMed should create bridges with these international organizations for developing a standardized framework for developing these personalized medicine interventions. And I'm happy to see that, yes, we can. And now we need to find a way to move forward. And thank you for this inspiring community.
Thank you so much. We do have time for 2 questions, but then it's time for our wrap-up and final closing of the workshop. Yes, please.
No, I am part of the group 4. Only a wording issue about the forum of policymakers. I am not very sure about the denomination of healthcare domain, because we need also the interest of politicians, economists, lawyers. So perhaps something like interested stakeholders, or only a wording issue in order to be inclusive of all the parties. That's all. Thank you.
Something like group of interest within the healthcare domain.
Something like that. Thank you.
Congratulations for the presentation. Only to say that I don't know if I didn't understand very well, but I don't share the recommendation of share only the successful results. I don't know if you propose that, because if we share only the successful, the patient that have a good evolution is not an evidence. I don't know. Perhaps I didn't understood. I didn't understand. Sorry.
Yeah, no. The idea is that there are already successful examples of personalized medicine, and we must demonstrate that personalized medicine is possible. And the idea is to tackle the ignorance of some decision makers that they still see personalized medicine as kind of some fantasy objective, and we want to demonstrate that this is possible. This is, I think, is a completely different issue. It's more on the dissemination side and pretty much focus on the policymakers and also on the public to generate trust and to generate trust about the reality of personalized medicine.
But the successful results, maybe with we can have it with any treatment. Everybody has some patient that had a very good evolution with.
Yeah, it's not successful result, but success stories.
Successful stories. Okay. No, I don't be sure that would be good. It's risky. Not a good evidence.
Okay, sorry, we don't have time for more questions. Sorry, we need to move on because I really want us to finish at 1 p.m. I know there are people need to grab a taxi. So thank you all, rapporteurs, for this. I think shows it's kind of very interesting to listen to you because you identify common denominators. Really, although you had different questions, it comes down to some main efforts that we need to focus on in the future. So thank you all for this. Thank you. Now, please stay in the room. We're going to change people. Now we're going to have the real powerful people up here. And during this transfer, Cristina has an announcement, please.
A little bit.
So.
Yes, good morning. Well, first of all, thank you very much to all of you for your attendance to the workshop. And I hope that it has been successful for you, all the discussions, very fruitful. And thank you very much for all the recommendations that we will try to implement some of them within ICPerMed. I had to tell you only two things before the closing session. First of all, as ICPerMed coordinators, I would like to tell you that the pre-announcement for the next call for next year is already in the website of ICPerMed. And our colleague from DLR are the secretariat for the joint transnational call. So please, if you are interested, consult the website. And the other thing is that after this workshop, there will be two back events. One of them is the cluster event that is organized by the REA and the European Commission. I think some of you are also attending to this cluster, and I hope that you enjoy also this event. And on tomorrow and on Friday, the summer school of ICPerMed will also be held. Some of you are also attending, some of them as speakers and others as attendants. And if some of you want to attend also, please contact our colleague Maria Jose from Italy that is in charge of this event. Thank you very much.
Thank you. And I actually suggest an extra applaud for Cristina, who's holding together all this conference.
You mean for the two of them?
Yes, of course.
And also for Raquel, because he's not here now, but all the intellectual effort of this workshop is of him. The logistics is for me, but the intellectual effort.
Yeah, we will certainly miss Raquel a lot, and it comes from my heart. So now this is not an easy task, of course, to have a workshop summary a couple of minutes after the working groups have finalized their conclusions and recommendations and so on. But I'm very happy then that I do have my colleague from the ICPerMed, who is the coordinator of ICPerMed, Ulrike Bushoff, over there. And she is going to try to bring together some thoughts that we had just before the working group started to summarize the work. So please, Ulrike.
So thank you very much. Thank you for all these fruitful discussions. It was very vivid, and it was nice to follow the discussions. But as Jan already said, it is really challenging to summarize these discussions, and obviously there's limitations to that. So what we will do thereafter, there will be the workshop report, and this is just to give you some take-home messages. But the real nice summary will still follow, and I really urge you to read the report thereafter, because this is the expert summary. This is just a try to give you some ideas of common denominators of the discussions we heard today and yesterday. And when we discussed what are the common denominators, one of them is building trust. I mean, one of the nice remarks from our Finnish colleagues again was it's just not enough to have informed consent. We have to do better than that. And this is so that might be that one of the common denominators of these discussions is building trust across the sectors. And the sectors, well, you can design that differently, but it's overall it's research, be it from the academic or from the industry side. It's healthcare systems and the society as a whole. So that's what we are trying to depict as a common denominator in these discussions. So if we look for building trust of all stakeholders in the research around personalized medicine, it's all about the quality, or it's all about data, in be it high quality, be it reproducible, be it interoperable. So it has to be from multiple sources to be really significant. And for that, you also, and this was one of the big themes in one of the discussion groups, it's you have to train scientists and enable them in methodology around trials in this area. It's all about data management and analysis, and we always mention FAIR in this context, but it's also about the pathways up to the market, and then again, always patient. It's patient empowerment, it's patient involvement, it's patient needs. So the nice word of co-creation is coming up there, and I loved the title of your paper. It's the management of the unknown. This thing around unknown. It's translating in a world of uncertainties. It's translating it into the real world setting, and for that, obviously, if the funders are also here, it's around funding really independent trials to get this evidence around here. So there was the call for a roadmap again, and for personalized medicine, and based on national research agendas. You correct me if I'm not citing that nicely. Okay. Then if we go for the other sector, healthcare systems, and also around healthcare systems, health policy decision makers, one of the topics around is always training healthcare professionals, especially physicians, pharmacists and nurses, the ones which are in real contact with the patients and the citizens. And this is, as we heard, it's not a revolution, it's not maybe a paradigm change, but it's a stepwise approach. But you have to prepare this change on a systemic level. So it's for that you need a pipeline. It has to be an integrated one, be it on a national or regional level, and reflecting the reality you have there. And again, patient empowerment, active and if really nice participation of all stakeholders. So we are repeating, these are one of the denominators in the discussions, so this is coming up in all of the working groups. There is a question and a discussion around upscaling. So we have nice local or even regional solutions, but always the policymakers are coming back with the question, so what about upscaling? Is it really feasible on a national level? And that's something we have to show. We have to provide evidence for that feasibility. And that's coming back also to the success stories. And sometimes maybe also not, the stories which didn't succeed, because we can learn a lot from these two also. So it's a kind of creating a portfolio of these kind of stories, and that's basically also what we're trying to do with ICPerMed, to provide a forum for these kind of discussions around research and giving the connection to healthcare domain. So I do agree, we need more patients, but it's really, we have to do that right in the discussions to reflect well the needs and to have a kind of involvement which is also giving a positive feedback so they're coming again. So we don't need them just for one point of discussion, we need them as a continued process. And for that, we have to make sure that we're building trust in what we are doing. And this is always, again, here, that's the other denominator. It's around safe data. It's around controlled access, and that means controlled by patients and citizens. For that, you need to tailor these education literacy programs, and you have to provide trustworthy sources. And trustworthy sources are around there. But if we don't have a label, how do I know as a patient or citizen that this source is really trustworthy? So this might be also a way of, adequate communication, so the way we transport the results we are creating with our funding programs, and these have to deliver on the needs of the patients and citizens. So again, we have the concept of co-creation with the patient community and the public for specific actions in personalized medicine. And this also brings us to the question of access and equity, and that's something we have to thoroughly discuss to come up with good solutions. So.
Thank you, Ulrike. for this very, very nice summary. We do apologize if you find that we didn't really pick up on your specific issue, but it's not an easy task to do a summary in this short time. I'm sure ICPerMed will got many ideas and recommendations for our future work and activities. Also think we need to narrow it down to some strategic actions of interest, but I also listen in that there are many here that also are in favor of widening the perspectives in personalized prevention, personalized health, not really personalized medicine. I also anticipate that there are very, very high expectations on ICPerMed. And of course, I thank you for this trust that you see in us. I also hear that there are very high expectations that Finland will solve a lot of issues. And we are neighbor to Finland, so we know Finland is really a good partner. But maybe it's not that difficult to understand since Santa Claus lives in Finland. So I will say something after, but first I will give the word to Indridi Benediktsson from the European Commission.
Thank you. So, Honourable Minister, Director General, ladies and gentlemen. So, from the Commission, I want to express our thanks to first of all, to the local organisers for arranging this workshop and all the different associated meetings. The whole week is full of meetings. Sometimes I'm getting a bit lost in all these different meetings, but that's great. It's reducing the carbon footprint. We only have to travel once. So that's it. It has been a great job that you've been doing. So many thanks to ISKI or ISTHI or ISSI or however you pronounce it for all the job you have been doing. And then also, of course, I would like to extend the thanks from the Commission to the ICPerMed Secretariat, the chair and the vice chairs and all the people involved in the ICPerMed initiative for all the work that they have been doing to advance the concept of personalized medicine for this initiative or movement, as somebody was calling it yesterday. I found that quite interesting to call it a movement. So I was joking with Jan-Ingvar that he's a Greta Thunberg of the ICPerMed movement. So thank you, Secretariat and chairs and vice chairs for managing the multitude of events and initiatives, not only this workshop, but throughout the whole lifetime of this project. And the vision paper is a great example of what can be done when people put their brains together. You are doing a fantastic job. Just sometimes you might have the impression that I'm not happy when I'm pushing you to the limits, but this is the truth. So keep up this movement. Yeah. It might not be so evident for some of us, but the discussions in these days in this workshop over the past 2 days are quite special. They are quite maybe not unique, but they are unusual. You do not have this kind of debate of informed brainstorming in many places or in many communities. You have all kinds of communities debating personalized medicine, of course. You have the scientific community, you have the medics, you have officials, you have industry representatives, economics, and managers debating among themselves the meaning of personalized medicine and then how to forward it. But you don't have often this kind of a mixed group coming from different disciplines and together coming up with recommendations. So I think we should acknowledge that and realize that this is something special. So for your thoughts on the way back home. This was not a wasted time here in Madrid. It never is in Madrid, by the way. So, this bringing together will make the difference when identifying what can be done, what should be done, and when, and how, and by whom. So these are the big questions that we need to address. The Commission has been very supportive of the ICPerMed consortium from the beginning and will continue to be so. We look very much forward to the exciting next couple of years I think they will be crucial in shaping the future rollout of personalized medicine in the practice in the healthcare system, not only in Europe, but among our international partners. And here ICPerMed can play a very important role and is playing a very important role. So finally, I will to wish you exciting continuation of this week and a safe trip back home. Thank you.
Thank you, Indridi. On behalf of ICPerMed, I need to thank the Commission for giving us this opportunity and this support that you give us. So then I'm giving the word to Raquel Yotti Alvarez, who is Director General for the Institute of Health.
Ladies and gentlemen, congratulations on a very successful event that I'm sure will be very useful to advance in the implementation of personalized medicine. I'm sure that through the discussions you have had here, you have found great ideas and solutions toward a smarter implementation of personalized medicine into our healthcare system. I encourage you to continue working on the identified topics you discussed in the working groups, for which I have rescued some issues previously referred. Citizens' empowerment. Never underestimate the power and the value of patients to change the system. Converting ELSI challenges into solutions. And, for instance, developing new ways of demonstrating evidence for a faster translation to patients. Transfer of results to citizens and industry. Technology challenges are, at the same time, market opportunities. Common understanding of personalized medicine for researchers and for the clinicians. And it's very important to consider its sustainability. Understanding ICPerMed from a global health system approach, but also taking into consideration what is being done at local levels, at regional levels, and keeping always citizens at the central issue, at the central point of care. I want also to congratulate those initiatives that received the best practice recognition. I'm sure that their examples will serve to build and illustrate our common agenda. You are aware, ISTI is very engaged in personalized medicine. We are very proud of coordinating the ICPerMed initiative, for which the third international joint call has just pre-announced. Within ICPerMed, we were able to select 57 joint projects with a global funding of around 60 million euros. I would like also to refer, as I did yesterday, to ICPerMed initiative towards the introduction of personalized medicine in Latin America and Caribbean. Now, ICPerMed initiative is now almost running its first year, and tomorrow it starts as training as another satellite event. Additionally, Spain is one of the 20 member states that signed the 1 Million Genomes initiative that should also play its role in convergence with this initiative, in particular for data exchange, sharing. It is our responsibility to try to build new partnerships, taking maximum profit on what is already done, what is already in place currently. Looking to the future, there is no doubt that personalized medicine should be an enabled discipline with the potential of transforming our national health system. So far, PN approaches has been mainly used for fighting rare diseases and cancer. Nevertheless, and in particular for prevention and treatment of other diseases with a strong genomic signature, such as cardiovascular diseases or neurodegeneration, personalized medicine has also an important role to do. In this regard, Spain and our institute is firmly committed to continue and support the initiative. To this end, and towards the potential EU partnership on personalized medicine under the next framework program, Horizon Europe, we will continue working for it, having the common understanding and aggregation of capacities and initiatives at European and international levels as foundation upon which the future of PM shall be built. To conclude, please let me a special thanks again to our ISTI team, in particular to Cristina and also to Candida for the great effort they have done. It's amazing the work you have done here during the whole week. It's been a hard work, but for sure it's worth it. I hope that the results of this workshop were more than satisfactory for all of you, and that you bring back some ideas and some thoughts and also more college to work with. Thank you very much and congratulations.
Thank you so much. And then I give almost the final word to Pilar Aparicio Azcárraga, Minister of Health, Consumers and Welfare. Please.
Thank you. First of all, I would like to... I'm not the minister, I'm sorry. I'm just the Director General of Public Health, Quality and Innovation.
Which is very important.
It's very important. It deals with a lot of things related also with the quality of the healthcare assistant. That is, I think, very important and dealing with many things that you have been talking these days. And of course, I bring you the support of the Ministry of Health and all the minister team. I'm very glad that you invite the minister to be in this closing act, but even if we are very well represented by our colleagues of the Institute of Health Carlos III, during all the jury and the organization of this, not only the organization of this workshop, but also being the coordinator for Spain. And for us, I think for Spain, it's a challenge, as we know that all the challenges you have been discussing these days, I think it's not necessary. The summaries of this workshop has been, I think, very good. I don't want to repeat the words, but I think we are very proud of our health system, and in a way we think that we start with our reform in the 80s of our primary health care with this integrated vision of health that now evolved to this precision medicine. And we were through different steps. For us, this step of primary health care was the first one, even if we know that now we need to renew and to rethink our model to be more, to answer better to the needs of the population, not only the demographic challenges, not only the chronicity, but also the new technologies and the new tools available for us. But also, I think Spain, during the last years, have been giving a lot of importance to the health information data. And I think we can be also very proud of our health system that integrates many data that we need to improve how to use this data, how to analyze, how to interpret this data. But it's true that we have a big amount of data, mainly proceeding from the health professionals, from the health activity. But we need also how to integrate all this data in a multifactorial, in a multidimensional and multidisciplinary teams that allow us to do a bigger step in the precision medicine. We have talked already these days and during this closing ceremony about the importance to incorporate to our clinical teams different professionals, as lawyers, as ethical people, citizens, of course, that this is a big challenge for us, how to incorporate all these different visions that we need to develop this precision medicine and to can answer, to integrate all the risk factors, all the factors that determine the health and the diseases of population to do a better particularized clinical care of all of our citizens. I want to bring all of you the support that the Ministry of Health give, and important that the Ministry of Health give the research and also how to develop a national project to deal with the precision medicine. We have already an interesting discussion in our Senate that give a national plan for develop the precision medicine, and for us, with the Institute of Health Carlos III, it's a big challenge how to bring step by step to be a reality with all the challenges that we have to that this precision medicine that brings so many expectations are safe, are ethical, and are effective. And it's for that is I want just to give and to bring all the support, all our commitment to go further in these steps. It's for that also that I not only congratulate your work here and your work every day in your countries, in your workplace, but also this workshop that I'm sure that is going to bring us necessary tools to develop this our future. This to conclude, I just would like to give congratulations and to thanks and to do all to bring you all our commitment, our strength for this that is very exciting initiative and very exciting perspective to get a better health for all our population. Thank you so much.
Thank you so much. We are running late, so I can't really give a long summary speak here now or giving my opinion on the next step on the strategic decision. So I'm actually going to repeat what you said. First of all, I would like to thank ICI for hosting this event, and the Minister of Health, of course, for being such a valuable partner in the European and international collaboration in personalized medicine, research and implementation. So thank you so much. But finally, and not least, I would like to thank you all participants, in particular chairs, vice chairs, rapporteurs, for a fantastic workshop, for actually reaching out here to have a very open-minded and friendly discussion and open up for different opinions and suggestions. So as you know, we will summarize this as a written report. It will be then published on the homepage and probably spread, of course, by all the participants. And it will most likely be an important instrument for us in our future activities and specific actions. So to all of you, thank you so much for being here. I'm very proud to represent ICPerMed. It's a wonderful organization with wonderful team members. So thank you so much. For those of you going home today, have a safe trip. Thank you so much.